At this time, though, I'm going to ask the secretary if she would go ahead and call the roll.
Senator Byrd. Here. Senator Harper Angel. Senator Storm.
Here.
Senator Westerfield. Representative Banta.
Here.
Representative Raymond.
Here.
Representative Stevenson. Representative Tate.
Here.
Representative Beckler.
Here.
Co-Chair Adams. Here. Co-Chair Meade.
Here. At this time, I will entertain a motion to approve the previous minutes. You should have had a chance to look over those. Those were in your packet that was sent to you earlier.
So moved.
We have a motion and a second. All those in favor, please signify by saying aye.
Aye.
All opposed, nay. Motion carries and the minutes are adopted. We're going to go ahead and get started and move through this. We have a lot on the agenda today, and I think that is Dr. Milner with us now? All right, we have Dr. Jerry Milner with us. I have heard Dr. Milner speak at several national conferences, and I wanted him to come and speak to us about what I have heard him speak about, especially with preventative services. I know that that is a passion for many of us in this room and something that we have pushed very hard for the past few years. But I enjoy his comments on that when we go to the conferences, but not only just the preventative services, but making sure that we are using the appropriate and the correct preventative services. So, Dr. Milner, thank you for being with us, and we will turn it over to you.
Well, let me thank the committee and thank you, Representative Meade, for thinking I had something to actually offer here. I'm always grateful for the opportunity to speak with policymakers about things that we can do better for children and families across the country. I've been. Let me go ahead and just ask that we advance to the next slide, if that's okay. I've been told real clearly I don't need to convince this group of why prevention is important, so I won't try to do that. For some context, however, and some basis for the things I'll say, I'll run through just a few things to make sure we're all thinking about this from the same starting point. We've got over 400,000 kids in foster care across the country right now. Most of those kids are in foster care solely due to whatever it is that we call neglect. Not necessarily abuse, physical abuse, sexual abuse, other kinds of abuse. And a lot of those children come from families where, with proper supports in place, they could remain safely together. Another part of that troubles me greatly is just the subjective and nebulous nature of the term child neglect. It may mean something totally different in Kentucky than it means in other states. I'm sitting in Florida. I have some of a sense of what it means down here, but it varies from state to state. I actually, when I was thinking about this, just realized a couple of years ago that I was what now we would call a free-range child. Could maybe have been picked up and put in foster care, not because I was being neglected, but because my dogs and I would spend entire days roaming around the countryside where I live. We do pick kids up and put them in foster care in some places in the country for that, and call it lack of supervision. The problem is worse if you're a Black child. You're about 2 times as likely to enter foster care as a white child. If you're Indigenous, you're about 3 times as likely, and if you're poor, you're always more likely to enter foster care. If you're one of those 20,000 young people who age out of foster care at 18 or 21 every year, you are at great risk of homelessness, not going to college or even completing more fundamental education. You are at great risk of going into the justice system, not being employed. And if you're a young woman, you're at much greater risk of becoming pregnant at a very early age. But more importantly, I think the kids who are emancipating from our foster care system are most at risk of carrying the trauma that they've experienced in their lives into the lives of their own children and own families, and have a perpetuating cycle. My philosophy is that our most substantial funding for child welfare should absolutely be on the prevention side, so that we can help to avoid so many of these painful and traumatic experiences that our families experience. When I was at the Children's Bureau in Washington for the last 4 out of 5 years, every year we were able to get into the president's budget proposal a potential piece of a proposal for legislation that would allow states to have the flexibility to use our largest pot of federal funding for prevention services, in addition to the cost associated with foster care. We were never able to get that picked up and sponsored and move forward, but we have real opportunities there if that's where we put our energies and put our investment of time there. Maybe we could move on to the second slide, if that's okay. I think prevention is something that we should all be concerned about. The issues that it raises are of importance to all of us, whether we're a part of the child welfare system or not. And when I talk about prevention, I am talking pretty specifically about the prevention of child maltreatment in the first place. Not necessarily the prevention of reoccurring maltreatment, although we don't want that to happen either. But if we're going to break some harmful cycles, reduce the trauma that our families, our young people, our children experience, we need to have into place those kinds of supports out there that will prevent the initial occurrence of maltreatment, particularly where we've got an opportunity to do that with the many families that are charged with neglect every year. I'm also talking about prevention of the trauma that often follows our responses. We have, through the Family First Prevention Services Act, some opportunity, not as much as I think has been heralded around the country, but some opportunity to try to address the trauma that follows maltreatment and children who are about to enter the foster care system by offering services to prevent entry. I am pretty vocal in saying that I don't think Family First goes nearly far enough in terms of addressing initial trauma, initial maltreatment, and primary prevention, but there is a place for it out there. Other things that I think prevention addresses is inequity. Our system is terribly overrepresented by families, children of color, poverty and homelessness, which so often follows so many of our children who spend their growing up years in foster care, as well as the pipeline from foster care to the prison justice system out there. Despite knowing this, I'm still amazed that, at least on the federal level, we tend to fund separation of families at exponentially higher rates than we are willing to fund prevention. And most of the funding comes late stage in child welfare involvement by families. I don't know of any other field that serves children and families out there where that's the case. Certainly healthcare has put a focus on prevention. Otherwise, why would we get a flu shot? Why would we get a COVID shot or other kinds of immunizations? The education field is very strongly oriented towards prevention kinds of things, even the auto industry and putting in safety factors out there. But that's not generally the case in our child welfare system. We've always been in a full force fix-it mode than we are in a mode of trying to prevent the trauma of maltreatment and family separation. We can move to the next slide, if that's okay. One of the keys, I'm not going to talk much here, but one of the keys I want to emphasize is that prevention should be family and community driven, designed by families and communities, operated by families and communities. We can empower them to achieve goals of well-being for the children and families that live in communities. I'm still kind of surprised when I am working around the country in different states, and I continue to see major policy decisions being made, major programmatic decisions, restructuring of child welfare programs without the active input of families and the communities that are going to be the most directly impacted by those. Let's move to the next slide, if that's okay. One of the things I wanted to spend a little bit of time talking about is how do we actually do this? Again, my sense is that the members of this committee know why it's important and agree that we need to support families before bad things happen. But somehow, how to do it is one of the barriers that we often face. I'm still for about the past year and a half, I've been working back out in the field in different states, trying to put into place primary prevention, family support, community-driven systems out there. And these are some of the things that might be worth thinking about just as examples. I think the first thing we always have to do is to address the values, the judgments about families who are involved in child welfare that tend to impede our investment, our commitment to supporting them. I believe with all my heart that the reason we couldn't get flexible funding in child welfare through even introduced really into Congress was around basic values and judgments. We have very much a save the child, rescue the child mentality, and oftentimes think pretty harshly about investing in parents who, with some support, could be the best thing that children need to address their circumstances. We have to ensure, as I've just said, parent and youth voice. I've sat down with parents who've been a part of the child welfare system, young people in almost all of the states now, and heard repeatedly the stories of what worked well, what did not work well. And it's become an essential part of my approach to doing the work and not making assumptions that I know better than they do about what's going to help their families. One of the very specific things that I think we can think about doing is investing in, I put family resource centers here, but other places call them family support centers, family success centers, community design supports for all families, not just those who are already in the child welfare system, but places where families can ask for help without stigma, can reveal their vulnerabilities without fear of losing their kids. As some examples, the Washington state governor, just within the past few weeks, I believe, signed legislation authorizing the creation of family resource centers there as a community-based prevention effort. New Jersey has around 85 family resource centers throughout the state and provides a safe haven for families to get the kinds of supports that they need without child welfare involvement. New York City is following that example and is putting into place resource centers that are totally designed and run by the communities. Other states are doing it as well. That may be happening in Kentucky as well, and I'm just not fully aware of it. One of the ways we move toward prevention is that we provide alternatives to mandatory reporting. I'll be clear and say, if a child's being abused, severely neglected, if there is an imminent risk of harm, a threat to that child's safety, I want a mandatory reporter calling that in to the child abuse and neglect hotline. That's not the case with most of the reports that come into the hotline. Most of the reports either don't rise to the level of needing actual intervention, or they're a plea for help. We have school teachers, healthcare professionals, others out there who can see families who need help. And the only place they know to go is a child abuse and neglect hotline, what often triggers a full investigation, and that in itself can be pretty traumatizing for families. Things like warm lines or other kinds of trusted community partners who can be called to get help for many families is a much preferable alternative than calling the hotline. I think we have to look very closely at our definitions of neglect. As I mentioned, they're incredibly subjective across the country from state to state. A number of states have recently implemented revised their definitions of neglect to exclude poverty as a reason for removing children. But when I'm out on the ground in the field, I'm still seeing what we call neglect as being traceable back to a family's lack of income. And maybe it's been allowed to go unchecked for so long that other kinds of problems are emerging as a result of that. But the bottom line is we're still removing kids for things like homelessness and inability to provide for basic needs, which are all in some way tied back to poverty. Having in place what I would call substantive reasonable efforts. We've had a reasonable efforts requirement on the books at the federal level for a number of years, at least 25 years now, that states have to make reasonable efforts to keep a family together before they separate them. Unfortunately, what I see happening, and I was vocal about this even while in DC, that's a checklist. It often just becomes a perfunctory exercise to say, yep, you made reasonable efforts because you offered what you had available, maybe not what a family really needed. I think we need to look very carefully at our state definitions of child neglect, not child neglect, but reasonable efforts to make sure that we're requiring the level of effort that's needed to help families stay together safely before we resort to separating them. I listed home visiting programs as an example. I'm sure that Kentucky has some of those programs in place. I've been fortunate enough to visit a number of those across the country, sit down with parents who I'm absolutely certain would have had child welfare involvement because of all the vulnerabilities, the risk factors that were there for them, had they not had the opportunity to connect with a home visiting nurse or some other supportive person, from the time of that child's birth, throughout the early childhood and development of the child. Unfortunately, a lot of the families I talk to are afraid to go the home visiting route because home visitors are also mandatory reporters. And families are afraid that if they do something wrong, they'll be reported to child welfare for neglect. But it hasn't dampened my enthusiasm for the programs and the support that they can offer to families. Universal community-based supports, I think, is one of the primary things that we can do to support families before child welfare involvement is actually needed. I think those kinds of supports and some of the best examples I've seen around the country are open to anybody in the community, not just somebody who has had a report made on them or who may be at the doorstep of their children entering foster care, but trying to ward off those things, those risk factors, before they turn into a crisis or escalate into very intensive involvement by child welfare. I also believe, even though I was a state child welfare director and spent 25 years in a state child welfare system, including carrying caseloads myself, I don't believe public child welfare can really be the face of community-based prevention services. I think we can be partners in that effort. We have to be partners in that effort, but the base of support really has to be community groups, formal and informal, that children and families can trust, and groups that reflect the culture, the background, the experiences of the families living there. Part of my push for flexible child welfare funding was to allow states to have those federal dollars to fund many of those groups directly and expand the range of community supports that's out there. Civil legal representation, I think, is essential for families. We were able to get federal funding in place for legal representation of families involved in the child welfare system. I'd very much like to see federal funding become available to support civil legal representation areas such as evictions, getting your utilities turned off, access to services, those kinds of things where families often are pretty helpless and can easily end up in the child welfare system. The last thing I'll mention, it's not on my bullet list here, but as we move toward prevention, we need to make sure that our Family First prevention services plans that are in place. In Kentucky, it was one of the very early states to get a plan in place. Make sure that they're as broad as possible. It was never intended to be primary prevention and to go upstream as far as I'd like to see it go. But I think that we do have some opportunities to make it as broad as possible and continually reevaluate our implementation of FIPSA, because it really is an essential component of our prevention continuum. Can we move on to my last slide here? And I'll try to make this pretty brief. I just wanted to mention, I've mentioned, a few places like New Jersey, New York, Washington, where some legislation is passed to support a move toward prevention. There's some other really wonderful examples out there that have influenced my thinking, my perspective on this whole area in a tremendous way. One of those is in Brooklyn, New York. It's called the Center for Family Life. It's been there over 40 years. I've visited with them a number of times, but it's totally community driven. It is most of the work occurs out in the community, a lot of it in the school systems, but providing things like family support, after school care, tutoring, recreation activities, even things like small business development for families, legal services, immigration services, help with filing tax returns, job readiness, placement, all kinds of things, advocacy that families need in order to get their needs met, short of coming into the child welfare system. The other one I wanted to mention, I'm about to head back out to Nebraska. I visited with them a few times, but to meet with a group called Bring Up Nebraska, which is really a public-private partnership. And in many respects is everything I've talked about in terms of bringing the community in for solutions, for approaches to serving families. 20 years ago, Nebraska had one of the highest rates of children in foster care in the whole country. But the legislature there implemented a prevention approach. It's called community response, which is a part of Bring Up Nebraska. And the rate of foster care placements has been steadily decreasing every year for about the last dozen years. It's really based on a premise that all families, all of us, will experience challenges and adversity at some point in our lives, and having early support by the community can prevent some of those from becoming crises. There are a lot of other examples. I'm sure there's some incredibly fine examples going on in your state, but I'm going to stop talking right now and open it up for any questions or thoughts that you might have.
Thank you, Dr. Milner, for your presentation and for being here today with us. We do have a couple of questions for you. I think Senator Byrd first.
Thank you, sir. That was a very interesting presentation. While you were talking, particularly at the beginning, when we were talking about where we intervene in child welfare cases, something called intergenerational trauma kept going through my head. And I have been actually studying a little bit about intergenerational trauma and the impact that it has on subsequent generations, both families that survived the Holocaust, to indigenous American Indians here in this country, to communities that have been impoverished for generations, and what that does to their ability, honestly, to raise healthy children. And I was just wondering, thinking about how do you fix this and how do you address intergenerational trauma, and it sort of goes back before the individual family to the community. And it just makes me think that maybe if we address this problem from that direction, that we could find a safer starting place for the individual children, if that makes sense. And I'm just wondering if that might help us reorient our thinking as to where it is as a state we should be intervening.
Yeah, I love the point that you're making. It's absolutely true that a huge proportion of the children who come into our foster care system right now are coming from families where that kind of historical trauma exists. I talk to parents every week who suffered incredible trauma themselves, didn't have the kinds of supports that they needed, and now they're going through this whole process again with their children. And I believe that's because we never put the kinds of supports into place to address that trauma, to prevent that trauma from happening to them, and or to help them deal with it if it's going to happen, despite our best efforts out there. As far as your thoughts about the community, I couldn't agree with you more. I think that's where we have to go. And any of these examples that I've shared with you today have begun with the community. That's where I think we need to put our resources, our efforts, and our support. I wouldn't even go so far as to call it an intervention. I think what child welfare does is an intervention after something has happened or a report is made or something like that. But when we start with the community, we start to put into place the kind of supports, the kind of environment where our families have a chance to deal with some of that trauma, some of the unresolved issues in their lives in a real non-threatening, non-stigmatic way. So I couldn't agree more that beginning with the community is where we absolutely have to go.
Thank you, sir.
Representative Raymond.
Thank you. I was particularly appreciative of seeing this recommendation of universal community-based supports. Of course, we've got families facing generational poverty, but I'm really interested in the fluidity of poverty and families who sort of come in and out on a weekly or monthly or annual basis. I'm sure coming up, we all had, many of us, we had big Christmases and we had very, very small Christmases, right? And so I wanted to ask you how you've seen these sorts of supports work. Families, of course, see and feel challenges sooner than any system. So could you speak to how you've seen families access these sorts of supports before they hit rock bottom, before anyone else necessarily knows that they need help, and how having fewer hoops on these sorts of things lead to prevention? Yeah.
Well, I'll address that. Let me say, as far as the families who come in and out of poverty, I think some of that is almost a little bit artificial. There's an article that has come out within the week, 2 articles, I think, in the New York Times around the great decreases that we've made in poverty. And I applaud that over the last 25 years or so. But we draw this line and say you're poor if you're under this line. You're not poor if you're by our standards. If you're above that line, and families drift in below and above the line. The fact is they're still struggling, and it may not meet the exact definition, but the financial hardship and all that entails is very often there. As far as how this works, I've talked some of the examples and ways that I've talked about is having what I would call a place-based kind of an approach out there, almost a safe haven for families to admit their vulnerabilities. I just recently published an article. It's called "All I Needed Was a Little Help, and They Took My Kids Away," and that was a quote from a mom I spoke with in a state. She finally mustered up the courage to go in and say, I don't have a suitable place for my family to live. She had escaped from a domestic violence situation. She said, I don't have enough money to put food on the table and to get my kids what they need to go to school. And as a result of that, her kids end up in the foster care system. And I think where we've got safe places in communities, trusted places, families can walk in and offer help. And ask for help without that fear. I think it makes families more willing to ask for help. They're not going to come to the public child welfare agency and say those things because they know what will happen to them. But I also think in those circumstances, and this is true in a couple of the examples that I've given today, we've got to have the range of supports out there that doesn't just take care of the immediate symptom that a family's experienced, but tries to get to some of the root issues there that are stopping families from becoming thriving families and becoming much more capable of meeting their children's basic needs. The Center for Family Life that I mentioned up in Brooklyn offers just such a range of those kinds of supports, in the schools where the kids are, after school, getting the parents engaged, involved, so much peer support that makes it seem okay for families to go in and ask for help. And I've visited those kinds of centers in multiple states like that. One of the, in terms of how it would really look, if we're serious about things being community driven and giving decision-making power to communities, it'll probably look a lot different in a lot of different places, rather than having a standard model that we think is going to work for everybody. But I think it has to begin with us engaging with our communities. At some point, we have to be able to fund those efforts, but we also have to trust communities to know what's best for their families and their children.
All right, are there any other questions? Well, Dr. Miller, thank you again. And as you were speaking, I really appreciate the part, as Representative Raymond said, of empowering local communities. There are many local programs out there, and I think that they need to be included in this as well. But also I think that includes faith communities. They can play a big part in this as well. And we need to have more of a partnership with those different organizations in those local communities. We started down a path in 2018 of putting together a program that will work very closely with local communities. And that has kind of stalled the last couple of years, but I hope that we will put more of a focus on that. Kentucky does rank first in abuse and neglect, and there's several times in our friends in the media want to leave out the last two words of that, and neglect. They want to say that we rank first in abuse, but about 75% of the children in our welfare system are there because of that neglect. And it's not that these families don't love these children, don't want to take care of these children. It's they lack the resources for that many times. And hopefully we can start changing that to provide those resources. Over the past 2 years, Kentucky's dedicated almost $40 million to prevention services, $20 million last year and about 19.8 this year. So I'm hoping that we can start turning this around, because the best thing that we can do is hold those families together. And one of the biggest issues that we have faced over the past few years, and a good friend of mine, former Representative Robert Benvenuti, used to say, poverty is not a reason to take children out of homes, that we need to provide resources for them. And I'm so glad that Senator Adams this year in her Senate Bill 8, she focused on that. She redefined neglect to say that poverty is not an excuse. And we're hoping that we can work closer with the cabinet to provide these resources for those families, and even those families who are suffering from drug abuse. I know that many times they fall into that. They want to care for their children, but they fall into that addiction, can't get out of it. And we need to continue to provide resources for them, like Volunteers of America and the Family Scholar House, who hold those families together while getting them drug treatment. So thank you again, Dr. Milner, for what you've said and for driving home that point today.
Yeah, thanks so much.
All right, we're going to move on in the agenda. We're going to jump around just a little bit. I apologize for that, but right now we're going to move on down to item number 6 with the discussion of administrative regulation and bring the cabinet up to speak on that. And as you approach the bench there, if you don't care, just state your name and position and go ahead and get started anytime you'd like to.
Hello, my name is Leslie Hoffman, the Deputy Commissioner for the Department for Medicaid Services, and I'm here on the behalf of Commissioner Lee today, who is not able to be present, who wanted to be present and not able to due to a family emergency.
Good afternoon. I'm Jonathan Scott. I'm Regulatory and Legislative Advisor for DMS.
You all can proceed anytime you'd like.
All right. We have been working diligently on 907K R3160 and on the Senate Bill 8 implementation that we needed to do when the bill passed in April. So we have we started out working on various ways to implement the legislation. Contains a requirement that we do a true and actual cost for the child advocacy centers. And so in our world, typically what we would do is we would implement an interim reimbursement rate, and then we would, at the end of the year, and starting in January, we would do a cost settlement with these facilities. And there's some real danger with doing that. We determined that when we started speaking to the centers, and then also as we started researching it, that if we do a true and actual cost that is a interim rate and cost settlement process, that they would have the potential to be exposed to maybe hundreds of thousands of dollars of Medicaid paybacks. We would be trying to recapture overpayments at the end of the year. So we have been attempting to develop a new reimbursement methodology that will satisfy the requirement of a true and actual cost, and will also protect these centers now and in the future as they go forward. So when you see this reg get filed, and hopefully it will be filed next week or the week after that, we will be filing a SPA no later than September 30th. You're going to see 2 reimbursement sections in the legislation, or in the regulation. So we will have a specialized fee schedule that we will be using for the first probably 6 to 12 months as we implement the legislation. And then after that, we hope to use a prospective payment system rate, which will utilize all of their costs from the prior year, and then give them a payment going for the next year. And if we do it this way, they will not be at any risk for having to pay a lot of money back. These are nonprofit centers, and we were just very concerned. They're nonprofit centers, and they have a low overall patient volume. So we expect their costs to really fluctuate. The other issue is, and these are all good changes. We are excited about Senate Bill 8, excited about implementing it. But we wanted to make sure that we do it right, and that's why there's been a little bit of a delay. We wanted to also mention that we will be able to pay them. We're able to reach back to July 1st and pay them for their full costs over the starting with July 1st for initially the enhanced fee schedule, and then hopefully as we get our cost survey process down, work with them to do the cost surveys, that they will be able to get their full reimbursement without the danger of them having to do a lot of paybacks. And we think that could be devastating to them if they had to, come into January and pay a substantial amount. We have also, I don't know if you all have seen a timeline that we provided. Did you all have the opportunity to review our timeline? And I'm trying to think if there's anything else we should mention. We hope, we also hope to move forward and defray some of their administrative burdens. We're going to require the MCOs to follow our cost surveys that we're going to do. We're going to be doing the majority of the work with working with the child advocacy centers, establishing a PPS rate, and we'll be requiring the MCOs to pay the rate that we're able to determine. And so we really want there to be a steady amount of a lessened administrative burden for the centers going forward. And then finally, we think that they're going to have a really good opportunity here to, we're going to expand their outpatient behavioral health services. So we've identified at this point 9 services that we anticipate that they will be adding, and services such as individual outpatient therapy, family therapy, group therapy, crisis stabilization, intensive outpatient, peer support services. So we think there's a good opportunity for them to begin to provide ongoing mental health treatment. We're going to treat that separately. We're going to require DMS and the MCOs to reimburse at 100% of our fee schedule, or at least at 100% of our fee schedule going forward. So that's an initial look at some of the changes we'll be making. Also wanted to mention we'll be adding physician assistants, and we'll be expanding the child medical evaluation to also include a trauma screening that is that is approved by the Child Advocacy Centers of Kentucky. So be happy to respond to any questions.
Well, thank you all again for being here. Chairman Adams.
Thank you, Mr. Chairman. First of all, I want to say I take umbrage with your use of the word diligent, because the fact that we had to bring you up here in front of this committee to ask you where you were on this regulation when the bill took effect on April 1st is embarrassing. It's embarrassing for the cabinet. And I'm quite honestly embarrassed that I have to sit up here and call you out on it, because diligent is not what is happening on this reg. This timeline that you gave to the members of the committee is word salad. It talks about how you sent an email or you're working on a concept. You have known since July of 2021 with testimony before this committee that these child advocacy centers were woefully underfunded and they needed this increased Medicaid reimbursement. Nothing happened after they testified here in July of 21. So I had to put it in Senate Bill 8 to require you all to up this reimbursement. We required it. So on April 1st, it took effect. Crickets. The governor inserted himself on June 8th by having a public bill signing at the child advocacy centers. I didn't ask the governor to insert himself. I didn't ask the governor to do a public bill signing. But that day on June, when he publicly signed that bill, ceremoniously signed it, he was stating to every member in the Commonwealth of Kentucky that he believes that this to be a priority. And the fact that we're sitting here on September 14th with nothing in front of us is absolutely, I think, a dereliction of duty on your all's part. And I'm just so frustrated. And very rarely do I get this worked up about an issue. But our children and our child advocacy centers deserve the attention that Senate Bill 8 has placed upon our situation in this state. Do you have any response to your use of the word diligent?
I'll simply say that it has been very difficult for us to determine how to use the true and actual cost, and that we have sought to examine a couple of different ways to establish a reimbursement rate that will protect these centers going forward. And we do not want to expose them to extensive costs at the end of every year. We're concerned that some of them could end up having to close if they had substantial Medicaid overpayments, and so that's why.
Tell me what substantial overpayment means.
If so, because the service has unbundled.
And we already know what true and actual cost is.
Yes.
We've known.
So since the service is unbundled and we are introducing 3 new provider types, we're introducing sexual assault nurse examiners, we're introducing APRNs, we're introducing PAs. We expect the front end costs to have some fluctuation. We also see that there's going to be 7 new services that they will be able to bill for individually, but also call a child medical evaluation. So there's going to be a lot of fluctuation. So if we determine an interim rate that is too high and they come to January and they have to pay $500,000 back to the Medicaid program, we're concerned that some of them might close in that environment. So we want to make sure that we give them a rate that reflects their true costs, that reflects their costs, but does not expose them to the danger of closing at the end of every year. We really want to avoid an overpayment. And we know that it's...
So the danger of closing by an overpayment is more important than these centers closing because they are woefully underfunded because we haven't raised the reimbursement rate since in 20 years. So that's not a valid argument.
Well, I apologize, but we are working as quickly as possible to implement this.
And just for the record, we've already had our first advisory meeting of the newly created board with Senate Bill 8, and this was a month ago. And I asked the cabinet at that board meeting, where are we on this increased reimbursement rate? And nobody from the cabinet could give me an answer. That's why I was shocked to see the word salad, that you've sent out an email or that you contacted somebody. It's been since April 1st. So I know I'm repeating myself at this point. But you all need to be doing a better job for the kids in this state than you're doing right now. Thank you, Mr. Chairman.
Representative Tate.
Thank you, Mr. Chairman. And I, too, appreciate you coming forth and giving us this information, minimal as it is. But, you know, just to add on to what Senator Adams said, in July of last year, we had some child advocacy centers that testified that the reimbursement rate was actually 25% of their actual cost. And so I can only assume with the current recession and inflation rates that that reimbursement rate is even less. So while you talk about your concern about them closing with overcompensation, I want to reiterate my concern about them closing because of undercompensation. So what can we do? Well, I guess what can you do to make this a priority of your organization and the cabinet?
This is a priority of our organization, and we are working diligently to get this regulation filed. We have a finalized version that we plan to share with the child advocacy centers on Monday. We've had meetings with them at the meeting that you attended last month. We had already been meeting with the child advocacy centers and sharing our draft reg. That was why we didn't send out a regulation with this interim rate and with this cost settlement, because we realized that they have a low volume, that they would be subject to overpayments, and they asked us to continue to consider a different reimbursement model, because they had a lot of concern that as a nonprofit facilities that they could potentially close if they have a lot of overpayments. And so I do understand that they have concerns about their existing reimbursement. That is something that we have also been reviewing, but I simply we could not in good faith send out an interim rate and a resettlement rate in the reg that we drafted. So
Okay, thank you.
Senator Storm.
Thank you, Mr. Chair. The timeline, this is the timeline that you prepared, sir?
yes, yeah,
Is that correct?
I think so. Yeah. Yes.
Okay. Talking about this, I want to go through this a little bit, if I may, Mr. Chairman. April 1st, the bill was signed, correct? Into law.
Yes.
In May, it says originally assessing. Then in May and June, strategy remained. Then emails were exchanged. In August, still anticipating. Dropping down still in August, it says assessing. Then you go down into just below that, it says still in August, hashing out reimbursement rates. September, still discussing reimbursement models. September 9th, what's going on? Discussing. Dropping on down to the bottom two-thirds of the page, discussing. Next steps, what does it end? Discussing. When are we going to start implementing what the General Assembly and the governor signed into law?
The regulation is drafted. We also have to do a state plan amendment process with this, where we will be forwarding information to the federal government, so to approve the regulation or the reimbursement changes, and to approve some of the additional providers that will be required, the unbundling of the service from. But through all of this, there has been drafted regulations, documents that have been shared and exchanged. It's not. I do apologize with the use of the word discussing. There are documents that have been going back and forth through all of this.
You created the timeline, though, correct, and used those terms discussing, hashing out, but never implementing, correct?
Correct.
What can we do as a General Assembly to make this a priority for the cabinet?
It has been a priority since it came through. We've just had a little bit more difficulty than we expected in determining the reimbursement rates, and then how the costs are going to fluctuate with the unbundling of the service and the introduction of the new providers. So it has not been a simple process for us to determine what a good interim reimbursement rate would be. So protecting the facilities going forward is an important consideration for us.
And protecting children, correct?
Yes.
Thank you, Mr. Chairman.
Do we have any further questions? Well, again, thank you all for being here. As you can see, these are passionate issues, especially when it comes to the welfare of these children. And I think that some of this frustration even goes much deeper than just this issue, especially with this committee and even with the General Assembly in general. We are passing laws that many times the cabinet and the administration are not implementing, and we are going to have to figure out a way just to force the issue on that. And so I apologize that you took the brunt of some of that today. I think that even though the commissioner may have had something come up, there should have been someone from the administration that should have been here today as well, and not thrown this off on you two. So we appreciate you being here. Thank you again. Next, I'm going to ask the Kentucky External Child Fatality and Near Fatality Review Panel to come up to give us their update. Thank you all for being here and what you do. And as you approach, if you would just state your name for the record, and you may proceed.
My name's Melissa Curry. I'm a child abuse pediatrician with University of Louisville and Norton Children's Hospital, and a member of the panel.
And I'm Steve Shannon. I'm the Executive Director of CARP, Association of 12, 14 mental health centers, and a member of the External Review Panel as well.
Hi, Alicia Mahoney with the Justice and Public Safety Cabinet.
Appreciate the opportunity, Chairman Mean, Chairman Rocky Adams, to talk about the work we do and how we do it. I think it's an important work. I'm a relatively newbie to the group, last 4 or 5 years, but it's really is the most challenging thing I engage in on a regular basis. So we're going to talk about who we are, who's on the panel. This is the first slide. We are chaired by a Fayette County Circuit Court judge. I call her 3M, Melissa Moore Murphy, Judge Murphy. We also have another judge, a family court judge, on as well, Judge Messler. So we really have the judicial piece. Commissioner of DCBS, Commissioner Miranda Straub participates as well. Significantly, we have 5 physicians that participate. They participate on a regular basis. In Oregon, there are 5. It's a big number out of 22, including Dr. Howard from UK, our good friend Dr. Curry from U of L. I learned more from Dr. Curry on this issue in 3.5 hours a month. I just can't imagine what she endures on a daily basis for what she has to do, and we appreciate that. Dr. Ralston participates. He's the you skipped one, didn't you? You're getting ahead of me. Sorry. The state medical examiner. We also have Dr. Jamie Pettinger, who's at UK as well, but she's to Prevent Child Abuse Kentucky. So we have those 5 folks. We also have other advocacy groups. We have the Domestic Violence Coalition participates. Now you can go. Thank you. Myself, we have another, Dr. Salt is a PhD level nurse, a lot of expertise, other groups represented. We have 7 vacancies, and if you look on that, we have a vacancy from the House of Representatives and the Kentucky Senate as well. The reality is, previously to Senate Bill 97, which was passed this session, the chair of the Senate Health and Welfare and the chair of the House Health, Welfare, and Family Services served on the panel. We changed that in Senate Bill 97, sponsored by Senator Carroll, to allow any other member of the General Assembly to participate. And that's why it's vacant. That process just hadn't been completed yet. They both have participated, we met twice in person, the hybrid thing, which is the no-brid thing in my opinion. But, we had those participate via Zoom, and that's useful. The other folks are still looking for members. Where'd it go? The prosecutor, person retired, rotated off. We have another retirement, Family Resource Youth Service Center, rotated off. So they're being filled. So we're going to get all these spots filled. It's important work, but that's who we are. Go ahead. And this is what we do, and this is really the panel process. Initially, our statute requires us to meet quarterly. We meet monthly now, and it's about a 3.5-hour meeting every month. My own personal experience, my wife can tell you when I've attended these meetings. It's a little somber evening that night, different thing. So, but how do we get cases? They come from DCBS. They make recommendations to us for cases. Not every DCBS case, not every person involved in DCBS ends up at our panel, but we get cases from there and from the Department of Public Health. Public health cases mostly involve SUDI, sudden unexplained infant death. How'd I do?
Good job.
I'm learning a new language every day. So that's, so that's how we get our cases. 2020, I think we looked at 200 cases, 80 fatalities, 120 near fatalities. So that's how we get them. Data collection. This group collects more data than anybody I know, and the reason for that is pretty significant, and I think Dr. Curry can explain it better than I can. We want to understand how we get these cases and what happens to families and children. I think Dr. Milner is dead on. We wish prevention worked. We're the opposite end of prevention, And if prevention really worked, We could go back to quarterly meetings, maybe have a longer lunch, but reality is this is where we live, and it's really the opposite end of the prevention process. But we try to collect as much data as we can about the composition of the family, the child, the events. I think there's 200 data points across 22 areas, so we have a lot of information we're collecting and using and sharing. The other thing we do is we discuss every case. Yesterday, I think we had 14 on our agenda, and we met for 3.5 hours, and we didn't get to one case. So we missed our mark because we spent so much time discussing the cases. And the discussion is powerful because it's a diverse group of people bringing forth different ideas. I come from a mental health substance use perspective, and I ask questions about that. But we look at those things and we try to understand what takes place in the meeting, and we rely on our physicians, our judicial system. We have a state police. They have access to information I didn't know existed. And they can tell us exactly where things are going and what's happening. And that's really helpful to us in those investigations. So that's important. We also look at the category. There's 23 factors that look at the category of what takes place. Some of these are abusive head trauma, all right? Blunt force trauma, gunshot, accidental, homicide, and suicide. These are things we're trying to figure out and discern. Correct me when I make a mistake.
Yes, sir.
All right. Physical abuse, suicide, we have the SUDI, smoke inhalation, sexual abuse, human trafficking. Those things happen in Kentucky on a regular basis, and we pay attention and we try to figure out what that is. The next piece we look at is what is the category? And these are really, it's the family characteristics, the category, family characteristics, get behind myself. And this is just not what the family looks like, okay, but it's who interacts with the family at different times, okay? I love Dr. Miller Prevention Community Based because the first family characteristic we have is bystander issues. Did someone else know about what was taking place or was suspicious about what was taking place, and that didn't get shared with somebody else? So it's really our bystander issues. And quite often in a case you'll hear afterwards, well, I wasn't so sure that the father was really taking good care of the babies, and apparently it sometimes appeared rough. Got that information 2 months earlier, our statistics could be different. We're also looking at domestic violence, financial struggles. Poverty is not a reason to be here, but poverty is real, and families really struggle. Who's the caregiver? A lot of single moms out there working really low-paying jobs. And I've said this to other committees, they have a boyfriend called a paramour. I dabbled in French at one time. Paramour is by love. It is the worst named relationship you can imagine. Because in our cases, there's very little love displayed by these folks who at times are taking care of kids and have no business taking care of kids because there's not another option for the mom who's working fast food, 5 o'clock to midnight. So you have a dad, acting like a dad who is no position to provide those services. So we see that, we identify that. Lack of family support system, We had family, we had friends who would help us with our kids when they were growing up. Doesn't always happen, paying attention to that. Substance abuse in the child, substance abuse in the caregiver, substance abuse in the home, because there's people in the house who aren't unrelated to the child who are abusing substances. Those are just a few. One thing I've learned more about is unsafe sleep. And I'm going to say I was a victim. Not a victim. My daughter was a victim. I was a perpetrator of unsafe sleep. She'd get up in the middle of the night. I learned I can go to a recliner, put her next to me, and I could rewind Snow White in my sleep so she would be quiet. That is unsafe sleep. No one told me about that. She's okay now. Well, maybe not. But, she's fine. But unsafe sleep is a real thing, and that happens on a regular basis. It's another characteristic that takes place. Then we make a determination of what happened, and those are 13 items. Neglect by the impaired caregiver. Neglect, inadequate, absent, restraint in motor vehicle. A bad car seat or no car seat, right? Medical neglect, not meaning the physician was neglectful, but the child had health care issues that weren't addressed. Didn't go for some reason. What is the answer to that? And our goal is to gather data. The last one is torture. Torture happens to kids. A young girl was locked in a room. This was a case just from last month. Her mom would give her, 2 ounces of water every hour and food. That's torture. That's what torture is. And we actually are debating the definition of torture. I think I know when I see it, but that's a real issue. So those are what we're trying to do and gather this information. All right, case reviews, findings, and when we get to the real meat of the substance recommendations, I'm going to hand it off to Dr. Curry because I think I'm in my head already. Let's look at case reviews. Oh, annual report. Sorry, forgot annual report. That is due. It was due December 1. Senate Bill 97 moved it to February 1, which fits our work schedule better. You know, we pick up 2 months one time. It's going to be 12 months after that, so we have that extension. Also, the annual report, we have made recommendations for the last several years, and they kind of go nowhere. You know, some DCBS will look at them, discuss them. There is no accountability to our recommendations, so obviously that creates some frustration for people who work hard on those recommendations. Senate Bill 97, passed by you this past session, results in us, the panel, probably Ms. Mahoney, sending those recommendations to the appropriate agency. And the appropriate agency has 90 days to either say, yes, we accept this recommendation and this is how we're going to implement it, or 2, no, we do not think this is an appropriate recommendation, so we're not going to implement it. But it helps us close that loop on many, many recommendations that have gone nowhere over the years. So at least we know where we're at. And if they don't accept it, I don't have a problem going back again with the same recommendation. And at some point, they'll probably say, okay, we're tired of reading this one. Let's see if we can address it. So that is a significant change to our annual report process. And it really creates an opportunity for what we see and what can be done in a more effective manner. Now, case reviews. Just a map of Kentucky, no surprise here, 120 counties. That green color, 13 in 2014 and 19, 13 counties we did not review a case from. I wish to tell you those 13 counties, kids were safe there. The cases just didn't get to us in those counties, I'm sure of that. But 13. But if you look at 2 to 4 cases or 5 plus, Jefferson County is going to be way more than 5, but that's just how we did our data. You're looking at a total of 89 counties had 2 plus cases over that period that we're looking at for sure. This is pervasive. This is not a rural issue. This is not an urban issue. This is pervasive across, all 120 counties. And I suspect if our data was through September 13th of 2022, we'd have fewer than 13 at this point. We'd have more. So this happens a lot. And there's no pattern, there's no guessing. We don't know what county they're in. The data people do, but it's across the state. There's no surprise. Go ahead. These are the age of the individuals we're looking at. These are the ages. Less than a year old. Less than a year old. Bad things happening to a 9-month-old. 31% of our cases. Less than 1 to 4 years old, 37% of our cases. So 68% of our cases are less than 4 years old. 68%. And these are the cases that get to us. Again, no reflection of the other DCBS cases. These are the ones we look at. 68% of 200 is 136 of 200 cases. That's what we look at. That's what we do. And we're trying to figure out, trying to understand, trying to make recommendations that we believe it can impact these numbers. Go ahead. These are our findings, okay? DCBS history, and it's important to note, and Dr. Miller touched on this, the intergenerational, and Senator Berg did. The DCBS history is families that had prior encounters with DCBS. We've had cases where the adult had DCBS cases as a child. We've had the grandmother who's now caring had DCBS cases. 69%, 7 out of 10 cases have prior DCBS experience. Financial issues, whether it relates to being able to afford housing, have resources even just to buy food. A lot are on Medicaid and get food stamps, but not everybody. So financial issues are just another stressor. Substance abuse in the home. Half had substance abuse in the home. We all hear about it. This is just a real way to look at it in measurement. Half. DCBS issues, and this is a really hard one. And I think my good friend Mr. Clark, when he was at DCBS, there was some tension between this group and DCBS, and I think that was fair. I think at times we were not collegial in our approach with DCBS, and fortunately we've moved away from that. And when we identified these issues, it's solely for the purpose of, can we address issues? We don't want to point fingers. We're not the DCBS overseer. But were there situations that maybe DCBS could have done something different and maybe a different outcome? But we don't want to be critical. I've said many times, the worst, hardest, most challenging, difficult job in state government is the DCBS caseworker. They're doing really hard things on a regular basis. Additional support, smaller caseloads, that's happened, right? We've added money in the budget for staff. Can we get those people hired and trained? So those issues. Half, again, supervisional neglect. These are who's responsible for the child. You know, who's doing that? Half of those cases. 3 out of 5, 62% of abusive head trauma cases, substance abuse by the caregiver. Substance abuse, again, by the caregiver. Blunt force trauma or motor vehicle, right? Impaired caregiver, drunk driver. Half of those cases that we identify in our process of categorization. Physical abuse, right? 62, 3 out of 5 again, with a criminal history. These are just things right off the top that we gather and we want to understand, and our recommendations are driven by these findings. And now Dr. Curry, our resident expert. Kate.
Thank you. Thank you, Mr. Shannon. And thank you to the committee and to the chairs for giving us this opportunity to share our findings and our recommendations with you today. I'm going to go through the 2021 recommendations as efficiently as I can. And I'm going to start with substance abuse issues. As you've heard, the panel made 6 recommendations regarding substance misuse and issues facing Kentucky families. Nearly half of all cases reviewed found substance misuse in the home, and a caregiver was identified as having a substance misuse issue at almost the same rate. So this is a tremendous problem, and there's no question, I don't think any of us are ignorant to the destructive impact that substance misuse has on child and family well-being. That's been well documented. So the panel recommended that the Administrative Office of the Courts develop a budgetary proposal to expand family drug courts throughout Kentucky. Family drug courts have been shown to be extremely effective at managing the substance misuse issue, and as well as having the children involved in the child welfare system and actually having collaboration around that. And checks and balances. The Kentucky Opioid Advisory Committee should examine this proposed budget and provide the additional required funding for implementation. And to speak to what Mr. Shannon just mentioned about our recommendations, this is the 6th year in a row that the panel has recommended a full implementation of family drug court in Kentucky. So risk factors such as mental health concerns, poverty, domestic violence, and criminal history are very common among the panel cases, as you can see here in this graph. Risk factors are found at significantly higher rate among families where substance abuse has been identified. So if you have substance abuse in the family, you have other risk factors too. Families with child welfare involvement and substance use issues require holistic services delivered in a multidisciplinary, strength-based, and collaborative environment. Kentucky currently has several evidence-based and nationally recognized models like the START teams and K-STEP. The panel strongly supports these efforts, but we have serious concerns that they do not meet the existing need across the Commonwealth, and we recommend expansion of these services. The panel documented 33 cases in which children were exposed to substances prenatally. 10 of those had a reported diagnosis of either neonatal abstinence syndrome or neonatal opiate withdrawal syndrome. This is very, very common. So we're talking about plans of safe care. We're talking about high-risk babies leaving the hospital with no safety net. And that safety net is federally mandated, but we have no one taking responsibility for it here in Kentucky. Overall, it's important to recognize that the panel is only seeing a small subset of the children who have neonatal abstinence syndrome or who are substance exposed. We're just seeing the ones that ended up having a near fatality or a fatality. So that's just a small percentage of them. The NAS registry, the Neonatal Abstinence Syndrome Registry, reported over 1,000 cases in 2019. So that gives you a sense of the percentage that we're seeing. So the panel has recommended that the Department for Behavioral Health, Developmental and Intellectual Disabilities, in conjunction with the Department for Public Health, should accept responsibility for implementing a plan of safe care and develop strategies to assure statewide implementation of collaborative plans of safe care that are consistent with the federal mandate. I think having ownership of these plans of safe care is so critical. They aren't going to happen consistently until someone takes responsibility for making sure it happens. And that has been the panel recommendation. Medication-assisted therapy for substance use disorder is an evidence-based practice, and it's an important treatment option for individuals with substance use disorder. The most commonly ingested substances that children are ingesting have been the buprenorphine, which is the narcotic that is in Suboxone, and other opioids, including fentanyl. We're seeing overdose ingestions increase, as you can see by the chart here, and these are just the near fatal and fatal cases. This is not counting all of the ingestions of illicit substances. It's important to recognize that sometimes the children are ingesting the Suboxone of their parents who are in legally, mandated or legally approved medication-assisted therapy programs, but a lot of times the Suboxone is off the street. And so it's illicit Suboxone that has been purchased to be misused, and that's what the children are getting into. So there are definitely opportunities for improvement that we have noted with medication-assisted therapy, primarily related to the needs of clients with young children. So educating those clients about safe storage of medication, giving out lock boxes, helping them understand the grave risk that these medications pose if they end up in the hands of a toddler. So the Kentucky Opioid Abatement Advisory Committee should consider funding medication lockboxes with educational material to MAT providers for their clients with young children in the homes. And the Cabinet for Health and Family Services should convene a study group to develop regulatory and contractual framework to support best practices for MAT providers serving clients with young children. One of the things that isn't mentioned here, but that I think is important, is we have a gap in communication. When folks are in medication-assisted therapy and they have young children in the home, they're regularly drug tested. If those drug tests come up positive for other illicit substances, that's not reported to the Cabinet. That should be, in my opinion, in my professional opinion. The Cabinet or some other member of the plan of safe care around that young child needs to know that there has been a relapse and that that child is now at risk, and there needs to be a plan for keeping that child safe. May or may not need to involve DCBS, but there needs to be collaboration and communication there. And I think it's confidentiality issues that get in the way. So here's a case study. We have a 1-month-old infant who died as a result of being overlaid by mother, meaning she laid on top of the infant in bed. Mother had overdosed on heroin. So father called 911 after finding the mother and the child. Father admitted that both he and mother used heroin around 1 a.m. Drug paraphernalia was located in the bedroom, which included a razor and heroin residue. The incident occurred at a relative's house where the couple had been staying. No criminal charges were filed against father. The infant's post-mortem blood toxicology was positive for fentanyl. So an infant was able to get adequate exposure to fentanyl, whether it was in powder form or whether it was being inhaled, and the infant breathed the air that had the fentanyl in it. The infant was exposed to amphetamines, buprenorphine, which is the narcotic in Subutex and Suboxone, and nicotine in utero and was diagnosed with neonatal abstinence syndrome. So this was a baby who was identified as being at high risk at the time of the birth hospitalization. A CPS report was investigated and unsubstantiated when the child was born substance exposed. Another referral was made 4 days before the death, but was not accepted for investigation. The parents met in rehab and both had significant substance abuse history. The family lacked stable employment, were chronically homeless. This case reflects the lack of statewide, consistent, collaborative approach to substance-affected families and plans of safe care. Suicide is the second leading cause of death for youth and young adults in Kentucky. So we identified that the Department for Behavioral Health, Developmental, and Intellectual Disabilities should begin expanding the statewide utilization of psychological autopsies in youth suicides. A psychological autopsy is a tool that involves a detailed review of the circumstances of death, including a review of medical records, and structured interviews with family members, friends, and healthcare professionals. It basically helps us understand what happened so that we can better prevent it from happening to other children. The psychological autopsy is conducted by a trained investigator who is certified by the American Association of Suicidology, and the panel is aware of only 2 individuals in Kentucky currently trained on how to conduct a psychological autopsy. Next is Safe Sleep. In state fiscal year 2020, the panel reviewed 20 sudden unexpected death in infancy cases. Understand that we do not review all of these cases, only the ones where there is an allegation of maltreatment involved. And many of those come from our public health referrals because they review all of those cases. Many of these cases are not reported to DCBS or are not accepted for investigation. Families in poverty struggling with substance abuse, mental health issues, and domestic violence were identified at greater rates in these cases. 60% of the SUID cases reviewed by the panel had financial issues. Half, as you've already heard, had substance abuse. Almost half had mental health issues, and 30% domestic violence. So these sleep-related deaths are not occurring in a vacuum. There are other risk factors that are present as well. So the recommendation is that the Cabinet for Health and Family Services should develop a plan to fund and implement a safe sleep campaign specifically targeted to reach high-risk populations. I do want to point out that the Cabinet is currently working on this. They are in the process of training foster parents and CPS staff on safe sleep education, and will be expanding that going forward. Finally, DCBS should review their current screening policies. So you just heard about the case of the child death where there were 2 CPS reports. One was investigated but unsubstantiated. The other did not get screened in at all. And that was 4 days before the infant died. So we're recommending that DCBS review their screen-in policies to ensure the adequacy of the existing acceptance criteria, to implement a supervision and management review process for referrals that involve children under 4, medically complex children, or families with multiple prior referrals, and to implement a process for professional reporting sources to seek supervisory review of decisions to screen out referrals they have made. So when a doctor or a child care provider or a therapist or a nurse makes a report and it's screened out, that needs extra attention because that was a professional who was making an objective report based on concerns. I will add here that DCBS is planning to implement a new structured decision-making approach. We have a panel presentation scheduled for October, and my understanding is that that implementation is due to happen in October as well. Next, the Kentucky Hospital Association and the Kentucky chapter of the American Academy of Pediatrics should develop a model protocol and training resources that addresses challenges to recognizing, reporting, and responding to situations in which healthcare professionals are confronted with families at risk for abuse and neglect. So we continue to see frankly, missed opportunities on the medical side, where individuals, whether they're physicians, nurse practitioners, nurses, whoever, see children with bruises, don't understand the significance of the bruising in a baby, or don't understand what a patterned injury looks like. Those go unreported, and then the child goes on to have a near fatality or a fatality. So we need better training there. Additional training required for coroners. The Kentucky Coroners Association should enact best practice for reviewing the child's death in both the county of residence and the county of death. This creates a significant challenge when a child is injured in one county and then is life flighted to another county for hospitalization, dies in that county. Where does the child death review occur? Best practice is to have it reviewed in both places, because both counties play a role and both counties can contribute to our better understanding of what could be changed to help prevent future fatalities. Additional training for law enforcement. The General Assembly should mandate all supervisors in the field of law enforcement to receive specialized training regarding child death scene investigations every 2 years. And finally, the Prosecutors Advisory Council should explore a protocol that would require county attorneys to conference with their local DCBS staff prior to hearings. And the council should provide additional training to prosecutors regarding obtaining criminal charges on caregivers when the child has ingested an illicit substance. That's the end of our formal presentation. We'll be happy to entertain questions. Thank you.
Representative Banda.
I just want to thank you very, very much for everything that you do, and I know you're appreciated, which I'm sure many days you don't feel appreciated. It just thinking out loud, thinking what we could do. Is there anything that we could publicly do with commercials and things like that to educate people? I think, I think about what we do around abortion, and then I look at this and I just want to just crack myself in the head. I guess I'm looking for answers. I don't have any. Your recommendations were great.
Thank you. In answer to your question, yes, I think there's a lot that we can do as far as educating communities. And I think Dr. Milner hit the nail on the head that it needs to be community-based, community-generated, community-owned, so that the messaging is done in a manner that can be heard and actually affect behavioral change. I think we do a great job of talking at people and telling people what they shouldn't do. We don't do such a great job of meeting them where they are and helping them understand the data for why we're making the recommendations we're making. So just simply educating caregivers so that they can make informed choices about how to care best for their children, I think is important.
I think the safe sleep is just a low-hanging fruit. I really think, and I talk about it, to the embarrassment of my family. But, I don't ask strangers or, but people I know, it doesn't take me long to ask that question. So I think that's something we can all do. You don't have to be an expert. You don't have to be a doctor, but just ask that question. I like golf. I watched the British Open. They had a commercial in Scotland, and you saw 10 quick pictures of Scotland. One of those 10 was a baby in a cardboard box, sounds awful, but surrounded by baby supplies. I knew that meant Scotland sent moms home with a sturdy box that could be used as a crib, not sleeping on the bed, full of supplies. They take it seriously. We don't take it seriously. I didn't hear about it. 2 daughters born, 97, 99. No one ever mentioned safe sleep to me. Never happened. Our cribs were full of crap. That's a bad thing. No one told us, keep your stuff out of the crib. So I think for me, the low-hanging fruit is clearly that one. We just need to be able to tell people what to do, how to do it, and go about our business. So, Remy, had a baby recently, right? Did anyone talk to you about safe sleep?
Well, I'll say Norton Hospital in Louisville does a wonderful job of educating
good.
families. But I was going to say we've recently been showing our older children movies from the 1990s. And you see crib bumpers in every movie before about 2000. Mm-hmm. And so I think about it all the time.
Yeah, we had them. Yeah, but I think that's the first step. And there's nothing you have to be expert in to say, keep stuff out of the crib. Don't let the baby sleep with you in the bed, no matter how great your ancestor, your grandmother told you that is. So,
Representative Beckler.
Thank you, Mr. Chairman. Thank you for your presentation. Looking at a slide that talks about most commonly found family characteristics, and in there you mentioned substance abuse, you mentioned impaired. Do you break down what the substance abuse is? Is it fentanyl? Is it just, percentages? Do you break down at all?
As far as the family substance abuse issue, no. If the baby is born with substance in the system, we do track that.
So this, when you say 62% of abusive head trauma cases involved substance abuse by a caregiver, this is kind of what I'm talking
yes.
to. So
It could include marijuana. It could include opioids. It could include methamphetamines. We don't necessarily break it down specifically by those numbers.
And often it's multiple substances.
Yes.
Yeah.
So it's difficult for the panel to determine what the substance of choice happened to be for that family. But we also have to remember alcohol, which is legal.
that brings me to my next question. You talk about blunt force trauma involved in impaired caregiver. What is impaired? Is that different from substance abuse? Does it just include alcohol? I don't understand it.
That's a good question. An impaired caregiver is any caregiver who's under the influence of a substance and is therefore unable to make adequate and safe decisions for the child. So that could be alcohol, marijuana, methamphetamine, fentanyl, any number, or a combination of all of them. So an impaired caregiver, in order to label it an impaired caregiver, we have to have evidence that they were using at the time of the death or around the time of the death, as opposed to it just being an ongoing issue with the family. Because sometimes the family has substance abuse issues, but they didn't necessarily use the night their child died. With an impaired caregiver, we have some evidence in the case file that tells us that that caregiver was under the influence at the time of the child's death. And so that's the difference between the two statistics.
It's tragic. Thank you. Thank you, Mr. Chairman.
Senator Berg.
Thank you, guys. This is always a very difficult meeting, and honestly, I never look forward to it. I have two questions, if that's okay. The first goes back to mandatory reporting, and when our first presenter said that he is not a proponent of mandatory reporting, the hairs went up on the back of my head, because it has been just inundated into me throughout my career how important mandatory reporting is. And that gets me to the other side of the question, which is, what happens when a child or a family is reported? And, we may be approaching this whole thing backwards. I don't know. We're not obviously making significant strides in fixing the problem. But I can tell you my personal experience in this state is that Child Protective Services doesn't go far enough. That they look into a family and from the outside they think, well, it's not the worst case we've ever seen, and they walk away. Or we have cases where they say they've already investigated this family, they don't open another. So trying to find the balance there, who's right? How much harm do we do with these investigations versus how much good? Who should be reported? Who are we reporting to? All of these are questions that I'm just floating around in my head. But quickly, can I assume that the panel is in strong support of continued mandatory reporting?
Absolutely. What I took away from Dr. Milner's comments about mandatory reporting is having an option for an alternative response. So not all reports need to be an investigation, but could have an alternative response with supportive services. And DCBS is piloting that in some counties right now. We used to have the FINSA track, Family in Need of Services, and an alternative response, and that went away for some years, and now they're bringing it back, which I think is a very good thing. But I could not agree with you more. I think that we have to be very careful about not in any way weakening what is a fantastic mandatory reporting law in Kentucky. We have one of the most broad mandatory reporting laws in the country. I'm very proud of it, and I think we would be very misguided if we change that in any way.
Thank you. Thank you for clarifying that for me. And then my second question, you briefly mentioned suicides. I didn't, and it's probably in here somewhere, I didn't see it. What was the number of suicides?
I'm going to defer that to Alicia, who has the report.
2 seconds, I will find that number for you.
And then a follow-up to that, with these suicides, are we looking into whether these kids are gay, are trans, are being abused at school or bullied? And do we have those statistics in this state?
Unfortunately, we don't have a lot of information about it because we aren't doing the psychological autopsy, which is where we would find out that information. The statistics are very clear that children with gender differences, LGBTQIA plus community, have a much, much higher risk of suicide. So that is very real, and that exists here in Kentucky as well. Alicia?
And we'll hear it if it's in the record.
Yeah.
So we don't get it beyond that, but if it's in there, so.
But that keeps us
Yes.
from actually
Correct.
keeping
Yeah, very
valid
much so.
statistics.
Correct.
If we don't have all the data.
Correct. And we reviewed 8 cases last year that were suicide cases. Now, keep in mind, we only review a small subset of all the suicides in Kentucky. There has to be that abuse or neglect element in order for it to get referred to us.
Yeah.
And then if there are any mental health issues or any concerns, we track that in our data as well. But again, it has to be present in the record. So.
Thank you, guys. Thank you for the work you do. I know how difficult this is, and the recommendations year after year, and not seeing things change has got to be beyond disheartening. So thank you for the work you do, and I really wish one day maybe.
Yeah.
Be all right.
Are there any further questions? I do have one question for you all. Go. Recently, we had 2 fatalities with children that were in state care residential facilities. Are you all reviewing those cases? Do you get those cases that of children who are in care and not just in their home? Would be the follow-up question to that as well.
So we will only get those cases if someone makes an allegation of abuse or neglect related to that death. And that is tricky because it happens inside a facility where there aren't outside eyes on that situation. And so we often don't have enough information to know whether we should be concerned about abuse or neglect in that case. I can tell you that in my program in pediatric forensic medicine at U of L and Norton Children's, we do get those cases of children who die or nearly die in residential facilities. And it can be very challenging to get accurate information out of those investigations. I will tell you, from a professional standpoint, I have serious concerns about allowing residential facilities to do their own investigations. I understand the importance of them doing their own investigations, but there needs to be some other eyes on there too. So that's me wearing my child abuse pediatrician hat rather than my panel hat. I'm not necessarily speaking for the panel here.
I can recall one case in my tenure that involved a facility.
And then, so I'm going to have one more question, which you may not be able to answer, but I'm going to ask you to see if you can point me in the right direction. So if I wanted to get information on some of those cases, or someone else committee wanted to get information on some of those cases, who is the person we should be directed to talk to?
I think that's a great question. The Office of the Inspector General will have some involvement with facility-related deaths and near deaths if they're called. It's not consistent that they're called, even though they should be. But that is probably a good start.
Okay, thank you all.
Maybe DCBS itself.
Yeah.
Because, they're, many of those places, they are the placement entity, so I think they would have information.
All right, thank you. Appreciate you all. All right, and our final portion of the agenda today is an update from the Kentucky Citizens Foster Care Review Board. It's always good to see you all. Thank you for being here and for what you do as well. And you all, if you want to introduce yourselves and for the record and then get started, you're more than welcome.
Good afternoon. I am Ebony Thompson. I'm the Family Services Manager with the Administrative Office of the Courts.
And I'm Cletus Pote, the State Chair for Kentucky Citizen Foster Care Review Board.
And we thought we would just start today by giving you a little background on the Citizens Foster Care Review Board program. So it was created as Kentucky's response to Public Law 96272, mandating that all children in foster care are to be reviewed at least once every 6 months, either by the courts or administrative review. And since its creation in 1982, it's been operating within the Department of Family Juvenile Services with the Administrative Office of the Courts. So CFCRB is comprised of over 900 volunteers across the state, whom after required training and approved background checks are appointed by the family court judge or district court judge in their local jurisdictions to do reviews on the children in the custody of the cabinet due to dependency, neglect, or abuse. The primary focus of the reviews is for the child and the parents to provide their progress towards permanency or the appropriateness of their child's placement. We currently have 174 local boards serving over 8,000 children in out-of-home care. And we have CFCRBs in every county within the state, with some of our smaller counties being combined and some of our larger counties having multiple boards. Since the passage of House Bill 1, we have been conducting regional community forums across the state at least twice a year. So far, we have done 44 forums. And these forums are for members of the public to discuss areas of concern regarding the foster care system and to identify barriers to timely permanency, well-being, and safety for children in out-of-home care. Initially, we had these forums in person, but since the onset of the pandemic, they have become virtual, and we do those via Zoom. But what we saw with that change is a significant increase in attendance, specifically with representation with our current and former foster children, our bio parents, foster parents, and relative caregivers. And we have department staff that combine those findings, and they give those to our volunteers to review, and they use those in drafting their legislative recommendations. And so the next several slides are just showing you our dates and locations of our community forums for our fiscal year 2022. So September 14th of 21, we were in the Western Kentucky area. September of 17, we were in Eastern Kentucky. September 22nd of 21, we hit Bullitt, Fayette, and Jefferson counties. And September 24th, we were in Central and Northern Kentucky. June 6th of 2022, we were back in Western Kentucky, and June 8th, we were in Eastern. June 14th, we were in Northern Kentucky, and June 16th, we were in Central Kentucky. And so from the fiscal year 2022 forums, we found these three common themes: the need for cultural awareness and representation, supports and services needed for families, youth, and caregivers, and overall system concerns. So regarding cultural awareness and representation, some of the findings we found was the need for increased awareness, understanding, and compassion regarding the impact that poverty, trauma, and bias has on families. Disproportionality continues to be a systemic issue in school systems, law enforcement, healthcare, community agencies, and mental health services, and emphasizing a focus on safety factors could help address disproportionality. Some suggestions for these barriers was unconscious bias training for child welfare staff and caregivers, diversity among guardian ad litems, foster parents, and Dcbs staff, partnering with minority communities to recruit more minority foster homes. So just basically to summarize these slides, they stress the significance of having representation in the communities that we serve. Regarding supports and services needed, the findings stated that biological parents need more detailed information about what resources are available, need more fatherhood supports, revisiting independent living rules and regulations to ensure children are being served appropriately. And our foster and adoptive parents are also wanting more information on resources and the exact services they provide. So basically, we have a lot of our parents who are just not familiar with what services might be already readily available. More findings were the lack of peer support, transportation, education, mental health services for families in foster care. Those continue to be barriers. The increased access to therapists, trauma-focused programs, family preservation services, crisis stabilization beds and short-term psychiatric beds, and then the need for increased broadband services, particularly in rural areas. And we know with the significant amount of youth being impacted by mental health issues, just stressing the fact that supports and services need to be prioritized. More findings is kinship providers have reported not receiving service referrals or equal consideration as foster parents. More foster homes are willing to work with children that have been trafficked or victims of sexual abuse. Needing more resources to assist youth in finding biological families after they're 18. More prevention services are needed in rural areas, and providing kinship placements access to managed care plans. And for our final theme, overall system concerns, just stressing that the youth need to have more of a voice in DNA proceedings, specifically when it comes to their future and their outcomes. Youth having limited contact with guardian ad litems, expansion of family courts, which we have our volunteers do support and have used these findings in part of their legislative recommendations. Delays in court process for a child's permanency by continuing the DNA case when parents have a criminal case. Staffing issues within Dcbs and private contracting agencies, which has led to some families being on waiting lists when needing services. And then obligations in case plans and or court orders that are sometimes not flexible enough for parents to fulfill obligations needed to get their children back. Parents are often required to maintain employment and housing while attending court, assessments, treatment, case meetings, various classes or programs. And these continue to be major barriers, especially in the rural areas.
Okay, thank you, Ebony. I will go over the current CFCRB legislative recommendations, and that's one of the...
Cletus, before you go any further, if you don't care, check just to make sure that microphone's on.
Is it on now?
There you go. Thank you.
Hey, sorry about that. One of our, we are statutory required to present CFCRB legislative recommendations, and this first one is the we've historically regarded the statewide expansion of family court as a high priority, and although that has been expanded in recent years, there's still many counties that don't have access to services provided by family court. And to further this cause, CFCRB would support a future judicial redistricting plan that increases the presence of family court, with the ultimate goal of expanding to every county in the Commonwealth. And this was also a sentiment that resonated throughout our forums, our community forums that we conducted, that many of the participants asked for that. The second recommendation is the statewide expansion and improvement of broadband services. And I know the Kentucky Wired project has been around for a while, but that needs to be expanded and improved upon, and delivery of that to allow affordable access to internet services for all the Commonwealth's children and families to enable successful participation in online services, including child welfare, education, medical platforms, and providing service delivery not only during states of emergency, but also to bring equity and service delivery to all Kentucky families. And this impacts the rural areas, and it was certainly manifested in the last 2.5 years that CFCRB have been conducting their reviews virtually, and those participants many times in rural areas, were challenged. I'll put it that way, with the virtual platform when the Wi-Fi availability was not what it should be. And the next recommendation is to amend KRS 620.190, and it's more of a housekeeping issue to allow non-DCBS employees of Cabinet for Health and Family Services to serve on local boards. The suggested language that we recommend is to change it from employees of the Cabinet to employees of the Department of Community-Based Services, so that other Cabinet members not directly involved with the DCBS could serve on local citizen foster care review boards. The next is recommendation is child serving agencies to gather data and address disproportionality and disparity for youth and families. And this has been a common theme through all the presentations that I've seen today, that support legislative and policy efforts that require child serving agencies to gather data and address disproportionality and disparity through annual strategic plans and reduction goals. These plans should include reviewing and updating criteria that identifies youth risk factors that may lead to negative activities such as gang recruitment and involvement. And this speaks to a more of a preventive avenue as opposed to fixing it. Creating and promoting strength-based asset building services and trainings to assist families and youth affected by these behaviors. And C, collecting and sharing data related to these activities. And our next recommendation, and it came as a direct result of the forums, the continuance of special services and service extension for transition age youth until the conclusion of the COVID state of emergency. Kentucky Cfcrb recommends this continuation of special services because those were some gaps, and especially those kids that are 18 to 21 that age out and are kind of left without direction and support. Any questions?
Representative Raymond.
Thank you. A quick one. Would you explain how looking at cases of neglect show up in your all's work, since we've heard some about neglect and how we might think about it in different ways today?
Well, when we get a case to review, it's gone to has a court assignment. It's already the child has been removed, and then as we as reviewers, our volunteer boards, the reason for removal is listed. It's either abuse, neglect, dependency, and there is a description in the case of what happened, how it happened, and what led to their removal. And of course, in our reviews, when we review it, and we may have biological parents, foster parents, CASA volunteers, of course the caseworker, guardian ad litems, Aetna, Sky program representatives, or what have you there, and we revisit that, and clarify what's in writing for us. And we refer to them as IPR, interested party, all parties touching that child. And the child in many cases is and for the last 2.5 years it's been in the Zoom meeting, but and we'll continue. But does that answer your question, hopefully? How? Well, I mean, and you can describe neglect in many different ways, but that's just one of the reasons for removal.
Representative Tate.
Thank you, Mr. Chair. And obviously, thank you very much for being here. I appreciate your presentation. This is a particular interest to me. I'm the founder of a Sierra's House, which is in Brandenburg, which is a transitional home for women that have been previously incarcerated. So one of the things that I see in here is that, and I love these, the legislative recommendations, love these. But by chance, do you also have executive recommendations? Because I think that there's potentially some latitude that the executive branch has that could help in this area, especially with the reluctance, I'm just going to say reluctance, not necessarily from the executive branch, but from society as a whole to incarcerate people. You know, a lot of the times the neglect and the abuse that we see, as we've talked about before, was caused from substance use disorder. And so it appears to me like that some of this neglect and abuse could be prevented upstream as opposed to reacting as we have. And so I would like to see if you've had any recommendations for the other branch as well.
I was going to say, we don't necessarily provide recommendations to the other branch, but we do have some programs that we're going to be initially implementing that's going to be looking into some of those concerns and issues. I'm not sure if you're familiar with the Kentucky Judicial Commission on Mental Health.
Mm-hmm.
And so when you said something about how we have women that have been previously dealing with substance use and those kind of concerns, though, that's the kind of committee that we'll have that can look into those kind of situations and can look into our youth and our families that are involved into the justice system and see what we can do to better improve any of those outcomes.
All right. Thank you.
And, you know, just for your information, these recommendations go to the legislature, they go to the Chief Justice, the governor sees them.
Mm-hmm.
You know, they're not just to the legislature. The Chief Justice gets them as well.
Okay. Thank you. Thank you, Mr. Chairman.
Senator Berg.
Thank you, guys. And I'm probably going to sound like I do not know what I'm talking about, but we have approximately 8,000 children in foster care. Are we individually examining each child's individual situation on a biannual basis? Is that what you're telling me?
Yes.
Yes, ma'am.
Okay. So that's where the children are coming from. Everybody in foster care is under this same level of review.
Yes, ma'am.
Awesome. This is a theoretical question. And I've really honestly been struggling with this because our society may be changing. And we may be needing to anticipate more and more births of unwanted children whose families are unable and incapable of caring for them as a result of changes in laws in this state. Has anybody given any thought to how the state needs to prepare for these children that we know are coming at us and are going to be coming at us hard and fast very soon, from women who are incapable from their circumstances of actually being safe, effective mothers, either because of poverty, abuse, dependency, or whatever issues that they're coming from that they would have chosen to terminate that pregnancy. Do we have an idea of what we need to prepare for?
So, I mean, to answer your question honestly, as a review board program, that's something we anticipate. It's more conversation about what we can do as a program to prepare for that kind of situation. So, honestly, we try to collaborate a lot with DCBS, but as far as being in a place where we're, I think, prepared, for I don't know if we're at that point and just being completely transparent.
Does anybody know if those discussions are happening on a statewide basis, or am I the only one who's laying in bed at night trying to think, how are we going to take care of these children once we get them?
And I mean, honestly, and I don't know if you have anything additional, but I was going to say cabinet and we have not had those discussions.
And to further answer your question about, your first question about are all of these cases being reviewed, the statute requires us to review them at least every 6 months. Some we will review as often as 2 months or 4 months down the road. If the circumstances at the time we review them, and we interview these people and write our findings, record our findings, and write our recommendations to the judge, and that goes to the judge. We can mark it attention judge if it's urgent, and we may bring that case back in 2 months, 3 months, 4 months, depending on what our recommendations are, to make sure that that has happened in that timely basis. We don't want to wait 6 months, so, and by virtual platform, we did not miss a case in beginning at the beginning of the pandemic. So it enabled us to make them all and to comply.
Thank you. Thank you for that work. That is extremely important. Very reassuring that it is actually being done. Thank you.
Well, thank you all. I don't think there's any other questions. Thank you all again for being here. You all have given us recommendations, and you have been actually part of legislation over the past. You're part of House Bill 1. You're part of some of the legislation we've done over the past few years. We have taken your recommendations. We've worked hard to put more emphasis on kinship care and for them to be given the same consideration as foster parents. We put that into a couple of bills. The guardian ad litem program we know has several issues. We have started looking into legislation for that, but we know also that Justice Lambert has been working on that program to try to revamp things there as well, so that the legislature doesn't have to get involved in that. But we've added family court judges, and we've done legislation to give children and foster parents more of a voice in that court process. So we're trying, but as we pass that legislation, again, it has to be followed, and so that burden is placed on someone else. But we hear you, and we are doing our part to try to do that. Right. But thank you all again.
We thank you.
Thank you. And FYI, Representative Meade, the subject of our September forums, we have 4 scheduled this September, is going to be, we always have a focus on each one of those forums. It's going to be on kinship care and some of the changes that are coming about, and get the feedback. So we get feedback. We also try to educate as well, so that's a subject of the upcoming.
Well, thank you all for what you do. We really appreciate you.
Thank you.
I think that sums up the agenda for today. Is there any other comments from the committee? Senator Adams, would you like to say anything? All right, with that, I will entertain a motion to adjourn. With that, we are adjourned.